Recommendations. The following recommendations have been arrived at, draw from the evidence reviewed. The report has highlighted the interplay between the 4 priority domains for health and social care reform and has captured the complexity of the NHS and the challenge of disentangling people's priorities for NHS reform for those related to primary care or social care. Furthermore, people spoke frequently about the importance of taking a whole system approach, taking into account the wider environment and public services which enable their health and well-being, including the contribution of the third sector. Some of the recommendations are quite specific, whereas others are broader, reflecting the context of wider system change. One, people want change, active involvement in implementation, and robust monitoring to ensure it delivers what is intended. An overarching theme evident in this review is that people want to see reform delivered that is informed by their priorities. Furthermore, priority must be given to empowering the role of people with lived experience in health and social care reform. Two, this review highlights some key alliance evidence concerning what is known about people's priorities. However, further work is needed to understand the wider evidence base. Therefore, Scottish Government should undertake further work to review other existing evidence, including drawing on that of third sector organisations. This work should take an equality-informed and intersectional approach to consider the experiences of different population groups, including, but not limited to, people receiving end-of-life care, unpaid carers, people from racialised communities, LGBT+ groups, and people with learning disabilities. There is a clear need to improve the monitoring of inequalities and evidence gathering across public services. In line with the recommendations by the Expert Reference Group on COVID-19 and Ethnicity, the Glasgow Centre for Population Health and LGBT Health and Wellbeing, this work should include proactive public health surveillance of the health, wellbeing and inequalities faced by different groups, including those with protected characteristics, LGBT+ communities. Three, strengthen the mechanisms for whole system, longer term integrated planning of health and social care services, enabling greater coordination and coherence across and between Scottish Government, the National NHS Executive to Health Boards, health and social care partnerships and local authorities. This planning should assess and forecast population needs now and into the future, monitor unmet needs, identify gaps in service delivery, plan for changing needs, and should be aligned to health and social care portfolio medium-term financial framework. There is also a need to strengthen the ongoing and meaningful involvement of people with lived experience in decision making. This should be done at both national and local levels. 4. Improve experiences of integrated health and social care and support. Our evidence demonstrates that more must be done to improve integrated ways of working, including across health services, between health and social care, and include the third sector, to address issues of disjointed pathways, delays, unmet need, a lack of accountability and follow-up. Five, Scottish Government, health boards and integration authorities must review their arrangements for working with the third sector and identify areas for improvement. The Alliance's evidence continues to demonstrate that more must be done to improve the engagement of the third sector as both a strategic and operational partner in health and social care. Despite strong evidence showing its vital role in providing support and services and essential social infrastructure to address health challenges, the third sector continues to be overlooked in governance arrangements and reform efforts. This work must be underpinned by adopting the fair funding for voluntary sector proposals and take into consideration the arrangements that are needed for the public sector to be effectively informed about, refer on, and signpost to the third sector support that is available in their areas. Access. 6. Improve and clarify pathways to ease navigation of NHS services, paying particular attention to boundaries between services. The challenges people encounter when trying to navigate their way through the NHS. With regards to information sharing, the coordination and continuity of care, and barriers to accessing services are well documented and require immediate improvement. The King's Fund has identified that high quality administration processes have the potential to improve a person's experience, reduce inequalities, promote better care, and contribute to a better working environment for staff, yet are rarely the focus of reform efforts. Our recommendations include: there needs to be a greater focus on guidance and support to create the conditions for multidisciplinary teams working. The GIRFE team around the person toolkit provides an opportunity. The introduction of an integrated health and social care record to support the sharing of information across services and ensuring personal and proxy access. Focused action to ensure equal access for disabled people, people with sensory impairments, people whose first language is not English, and those who face structural and systemic barriers. After carrying out a review of existing evidence, Recommendation 2, if there are data gaps, the Scottish Government may need to commission further community-based research to understand these issues and highlight solutions. Promote existing guidance on inclusive communication and instigate a programme to raise awareness, support implementation, and monitor its application. Seven, priority must be given to people's communication, information, and support needs. Key to being involved in maintaining one's own health and well-being is having access to the right information in the right format at the right time. This allows individuals to understand their health and well-being options, giving them greater control over their care and informed decision making, and increases people's capacity to self-manage. Scottish Government and NHS boards must improve and embed inclusive communication strategies and approaches which ensure people have access to the information they need to be informed about their health, to access support and services, and in relation to related matters. This includes, but is not limited to, information about accessing transport to health services and support for digital inclusion. Access to appropriate information and resources are key enablers in supporting self-management. 8. People's access needs must be prioritised to ensure both individual and population needs are more equitably met. There should be a greater focus on choice, flexibility and availability in service models, which allow people to access service in ways that better meet their rights and needs and ensures that digital is a choice, not a requirement or expectation. Nine, the challenges of accessing certain NHS services must be addressed. For example, where there are long waiting lists where the service is identified as fragile and/or eligibility criteria are applied to manage waiting lists. There must be greater transparency and participation of lived experience with the identification of fragile NHS services and/or services where eligibility criteria are applied to manage waiting lists. This must take into account regional variations, including where this affects remote and rural parts of Scotland. Scottish Government and health boards should undertake and publish a review into which NHS services are fragile, in which parts of the country, and where access problems are most challenging. This review should involve people with lived experience in this process, have a focus on working towards solutions, and take into account the contribution the third sector plays in delivering services. Enhance availability and accessibility of emotional and psychological support during critical life and health events, including but not limited to diagnosis, pregnancy loss, palliative and end-of-life care. Quality. 11. Prioritise person-centred and relational care as a guiding principle of reform. Research and engagement by the Alliance into experiences of person-centred care continues to highlight shortfalls. This creates barriers to access and negatively impacts health outcomes. We have identified the core elements of person-centred care as feeling heard and listened to, being treated with courtesy and dignity, experiencing empowerment, feeling trust during interactions, feeling understood by healthcare practitioners, having good relationships and not being judged. These are strongly aligned to the GIRFE principles, which could prove to be a guiding approach to the NHS reform programme. 12. Prioritise training and professional development in person-centred care as part of workforce recruitment, retention and development planning, ensuring a focus on equality, rights, inclusion and trauma-informed approaches. Related to Recommendation 11, the evidence review has highlighted the importance people place on person-centred and person-led care, and the negative impact where this is not encountered. It is essential that priority is given to ensure the workforce develop the training and skills required to deliver person-centred care. Our evidence has highlighted the following to be of importance. Trauma-informed approaches, e.g. the National Trauma Training Programme. Gender sensitivity. Sensory awareness training, including a strong understanding of device management. Understanding mobility requirements. Awareness of systemic inequalities and ability to take an intersectional approach such as equality and integration modules. Cultural awareness. Inclusive communication skills. Tura's person-centred care zone. A human rights-based approach to dignity and care. NES Introduction to Equality, Diversity and Human Rights. LGBT+ inclusive training. 13. Adopt the House of Care approach, enabling person-centred care and the practice of realistic medicine. House of Care is a coordinated service model that enables people living with long-term conditions to be in the driving seat of their care. It addresses health inequalities, builds health literacy, and supports public health aims. Underpinned by self-management principles, House of Care builds people's confidence and ability to manage their conditions. It does this through information gathering and sharing prior to a collaborative conversation which involves goal setting and action planning. With the person knowing their numbers, e.g. blood pressure, lipids and so on, in advance of a care and support planning conversation, they have a sense of empowerment which leads meaningful and informed conversations about their health and condition management. Evidence shows that this type of supportive, collaborative relationship can lead to improved health outcomes, especially when it's fully integrated into primary care delivery. Though used mainly within the primary care and long-term condition management context, the House of Care collaborative, person-centred conversation can play a significant role in prevention. It can go further than where health check initiatives have gone by combining measurement of key risk indicators with motivational interviewing and goal-setting techniques to influence behaviour change and reduce potential impact of unmanaged risk factors. This allows people to take part in shared decision making and be more in control of their own health and well-being. Prevention. 14. Create and publish a funded plan to shift resources over the medium to long term from acute to prevention-focused, community-based and multi-stakeholder delivered care and support, including primary care. 15. Explore adoption of a community health hub approach to prevention and diagnostics. A community health hub model of care that is planned and implemented in collaboration with healthcare partners and the third sector and tailored to the needs of the local community could transform everyday spaces into healthcare settings and move preventative care from a medicalised primary care setting to places such as shopping centres, places of worship and leisure centres. Accessibility is increased by providing walk-in and out-of-hours service closer in proximity and in more familiar locations, making appointments easier and cheaper to attend while balancing work and caring responsibilities. Health hubs can also reduce health inequalities by addressing barriers to attending more traditional, centralised spaces of care faced by deprived, minority ethnic and rural communities, as well as specific social demographic groups including carers, disabled people and younger and older people. Community care plays a key role in creating health value, with NHS research showing that systems that invested more in community care saw 15% lower non-elective admission rates and 10% lower ambulance conveyance rates. The Health Hub approach presents a dual opportunity for individuals in preventing ill health and deterioration of existing health conditions, as well as the potential to relieve long-term pressure on primary and secondary healthcare services. 16. Strengthen community-based mental health services. This will improve accessibility and promote a sense of local, easily accessible and available support. It could include integrating perinatal mental health services and support for those experiencing miscarriage or stillbirth into community settings. 17. Widen access to community-led self-management support for people across Scotland. The value of support for self-management is well evidenced, including through Scotland's Self-Management Fund. The investment Scottish Government has made to investing in community-based self-management approaches is an asset to build upon, yet there is a need to support the sustainability of these approaches and widen access to support for people across the country. (18) Providing greater support to the third sector should be seen as an investment, not a cost. Ensuring continuity of provision for the services people rely on to help them live well and better pay people employed within the sector will improve well-being and keep people out of poverty. As a result, people will be less likely to need more costly emergency interventions from statutory services, including the NHS, saving money in the longer run. Guarantee sustainable investment for third sector services that help prevent people's health and well-being from worsening and placing more demand on NHS services. By empowering individuals with long-term conditions to better manage their health and providing resources, knowledge and support to do so, people have a sense of empowerment, healthcare practices are enhanced and ultimately the creation of a more sustainable and effective health and care system in Scotland. (19) Ensure people have access to flexible, person-centred nutritional, physical and psychological support before, during and after treatment as part of a continuum of care based on individual needs. The role of prehabilitation and rehabilitation must be elevated to reduce treatment-related complications and enable people to return or maintain a quality of life. For example, for people preparing for cancer treatment, cardiovascular surgery, or to support recovery including from substance use. People in place. 20. Recognise that many actions that are needed to tackle health inequalities sit out with the health and social care system. This requires a joined-up health and wellbeing first approach across multiple policy areas, e.g. transport, education, housing, poverty reduction. Maintain a whole systems approach to reform by embedding NHS reform within the broader programme of public service reform, ensuring that equality and human rights issues are integrated into reform metrics, including taking into account the needs of remote, rural and island communities. Health boards and integration authorities to use existing opportunities like the Public Sector Equality Duty Outcome Setting Monitoring Process and the Population Health Framework to identify and target population groups who may require more specific targeted action. This should also align with existing action plans, such as the Transport to Health Delivery Plan. Public bodies should ensure that robust equality and human rights impact assessments, EQHRIAs, or integrated impact assessments are completed at the earliest possible policy planning stage to inform and direct decision making, as well as used to monitor and evaluate the impact of interventions. EQHRIAs are comprehensive. They allow for planning to focus both on at-risk population groups and all relevant rights, like the right to health.